Good morning, everyone. I'm Chiang from Kaohsiung, and I would like to introduce the new tumor ablation agent called PTS. And PTS is a liquid looks like lipiodol, a fluid with high viscosity. And however, it could be injected directly into the tumor, just like ethanol. My talk is intra-tumor PTS injection for HCC management. And my talk will be divided into 3 parts. First, a basic introduction of PTS 100. And the second, the PTS mechanism of action. And finally, I will show you several cases from our early clinical experience. And the active ingredient in PTS is PTSA, the paratoluene sulfonamide, which is a low molecular weight organic compound with potential to do anti-neoplastic activity. And it is a hydrophobic agent. And this agent was created by Taiwanese and made in Taiwan. So it's really a Taiwan 之光. Indeed. So, from the laboratory studies using the human tongue's SCC cell, and they found the PTS was found to be selectively accumulate in cancer cells in a dose-dependent manner. Which means if you inject more PTS, then the PTS will more selectively accumulate in the cancer cells rather than a normal human gingival fibroblast cell. And when more PTS accumulated in cancer cells, it will induce lysosome membrane to damage and release more proteolytic enzyme and eventually lead to cell death. Another mechanism is about the cell membrane. We know that lipid rafts are special areas in the cell membrane, which regulate important signal pathway to transport signals and proteins that has many key roles in the cellular processes regulations. And the PTS shows some functions to cause lipid rafts and cholesterol disturbance and make the signal pathway to be inactivated. And then induce mitochondrial dysfunction and hold the cell cycle arrested at the G1 phase and then trigger apoptosis. And this finding was found in the prostate cancer cell. And also the similar mechanism was also found in the non-small cell lung cancer cell models. Again, the PTSA disturb the lipid raft and block the AKT and mTOR pathway and cause the lysosome to damage, induce autophagy mechanism, and then hold the cell cycle at the G1 phase, and then trigger apoptosis, a specific cancer cell death. Another mechanism is PTS is also a potent CA9 inhibitor. CA9, carbonic anhydrase 9, which is an important enzyme to help cancer cells survive in hypoxia and acidic environment, allow cancer cells to escape from immune cells and allow cancer cells to grow, to invade, and to spread. It's a very important enzyme for cancer cells. And we found that with more PTS, the CA9 activity could be inhibited severely. In another mice studies using triple-negative breast cancer cell, the group treated with both PTS 100 and anti-PD-1 therapy showed the best results with much smaller tumor size and much less distant metastasis, the purple group. And then let's look at how PTS works inside the tumor. Its effect can be divided into 3 parts. The first zone in the center with the highest concentration. Within 4 hours post PTS was injected. The main effect is chemical ablation. And then 4 to 8 hours post PTS was given. With median concentration in the outer world, with the PTS diffusion a little peripheral. And the mechanism is chemical ablation and apoptosis both. And the outer zone, the outest zone, the third zone is the area between the tumor cell and the normal parenchyma. the PDS will selectively accumulate in cancer cell and trigger specific apoptosis. So it works in layering with the stronger chemical ablation in the center and the specific cell apoptosis toward the edge. Then I will show you several cases in our clinical practice. Here is the toolbox for PDS injection. PDS was packaged in the vials with 5 milliliters per vial. And also we need some local anesthesia. And because PDS is a fluid with very high viscosity, we need a core needle, 18-gauge needle to aspirate it. And a 3 milliliter locked syringe and the extension tube with lock. The lock is important because we don't want the PDS to leak during injection. And we usually use a 21-gauge Chia needle only. So it's a very minimal invasive procedure. PDS 100 can be administered under ultrasound or CT guidance procedure. The brief PDS injection protocol are as follows. The indications are usually residual or recurrent lesions after standard treatment, such as surgery, TACE, RFA, etc. And the lesions are not suitable for operation or with high risk for other local therapies. And the target lesion number is usually less than 5. The major contraindications are lesions that are infiltrative intravascular location that cannot retain PDS 100 long enough to be onset. So the protocol is to push the Chia needle tips into to the far end of the lesion, and then gradually retract the needle and wait for several seconds for the PDS to spread. And then we simultaneously retract the needle and inject the PDS along the needle tract. The planned PDS dose is at least 30% of the tumor volume. Of course, the more the better. But the maximum dose, 10 millimeter per day per session. It is ideally to complete the treatment course within 1 week. Here I will show the first cases. The first case is a 69-year-old man with HCC, underlying liver cirrhosis and HCV carrier. He was initially diagnosed as HCC with depth vein and visceral peritoneal invasion in 2022, and clinical stage is CT4 and 1M0, and BCLC stage. And he experienced HIC course for 3 cycles. However, he didn't like HIC, so he continues with lenvatinib. However, the tumor continues to progress, so he returned to receive HIC again. And however, even the most of the tumor shows better control under HIC. However, there were 2 viable tumors at the right liver, shows continuous refractory to HIC treatment, about 5 to 6 meters. And the patient was little negative, and he didn't want any aggressive treatment. So we arranged PDS for him. The first lesion tumor volume was about 85 milliliter, and the planned dose is 30% of the tumor volume, about 25 milliliters. The second lesion tumor volume was about 58 milliliter, and the planned dose was about 70 milliliter. The treatment course for the first tumor was divided into 3 injections, 10 milliliters first, and then plus 10 millimeters. And then the patient feel a little discomfort, abdominal fullness, so the third injection was delayed 6 days later. And after PDS injection, 2 months later, we can see there is a significant central tumor necrosis in this lesion. And the second lesion, the treatment course for the second lesion was divided into two injections. And the first injection is 2.5 milliliters, and the second is 10 milliliter. And also, 2 months later, the lesion shows evident central necrosis. The outcome is more than 70% of intratumor necrosis at both lesions, with no surrounding tissue damage, partial response by M-RECIST criteria. The patient experienced mild side effect, maybe because the lesion is very close to the bowel loop. And the patient feel nausea, vomiting, abdominal fullness, but all the symptoms relieved in a few days under conservative treatment only. Here are the pictures when I injected PTS. We can see that on the ultrasound, the area post-PTS injection showed mild hyperechoic change. And under on non-contrast CT study, the area post-PTS injection showed mild hyperdense change. The second case was a 87-year-old man. He was very old, and he first got HCC in 2016 and cured by IFA. However, HCC recurred 7 years later, and he underwent tests for 6 times. Most lesions are under control, but a viable tumor. But the last tumor, only one viable tumor at the S8. It shows very difficult for embolization. He also got a pacemaker implantation, and he said, "I am very, very old. Please, no more aggressive treatment, no more painful treatment." But we all know that no pain, no gain. Also, but maybe PTS could be one of the exceptions. So we arranged PTS for him. The image before PTS is that the tumor is located as high, very high at the liver dome, and between a hepatic cyst and the heart. The treated tumor volume was around 47 milliliter, and the planned dose was about 14 milliliters. The treatment course was divided into 2 injections, 5 milliliter and plus 6 millimeters. And because of the cyst, I don't want the PTS to leak into the cyst, so I take a detour via the transpulmonary injection. Transpulmonary route. I insert the chip needle through the lung into the tumor. And you can see that under the non-contrast CT, the post-PTS injection area shows mild hyperdense change. And the second injection, I put the needle a little inferior part, at the inferior part of the tumor. And surprisingly, 2 months later, the lesion shows complete response by MRECIST criteria. We are all surprised. The third case is a small lesion at S5. Because the patient had experienced multiple surgeries, multiple metastatectomy, multiple IFA, and multiple TSCE, and he also got a pancreatic head cancer post-Whipple operations, and post-OP complicated with massive bleeding. We have made a hepatic artery stent for him. So for him, both IFA or transarterial treatment are risky for him. So he was agreed to receive. So he agreed to receive PTS injection. And after injection, 2 months later, the lesion just completely disappeared. So he didn't experience any adverse event. In summary, PTS has many advantages in treating our human cancers. First of all, it can be directly injected into the tumor with a minimal invasive procedure, and it can accumulate selectively into the tumor with less damages to adjacent normal tissues. And also, it has broad indications for various kinds of human tumors, and it is very safe with a short hospital stay and good patient compliance. In conclusion, PTS may complement our standard treatment and enhance our local tumor control. Thank you for your attention.